Hello and welcome to this PLAB 2 preparation video focusing on the symptom of blurred or lost vision. In this session, we will explore the key differentials you should consider when a patient presents with changes to their vision. We'll discuss important questions to ask, investigations to perform, and how to manage or refer these patients. Let's begin with a general approach. Always start by asking specific questions, such as whether the patient experiences floaters, flashes of light, wavy lines like seeing them bend or warp, or halos around bright lights. If the patient mentions headaches, especially those that are temporal or worse in the morning, or that get worse when bending forward or combing their hair, you should immediately consider giant cell arteritis, GCA, or idiopathic intracranial hypertension, IIH. These conditions are very time-sensitive, so it's crucial to pick up on these clues early. Let's talk first about giant cell arteritis, GCA. This condition often presents with sudden vision loss alongside systemic symptoms such as headache, scalp tenderness, and muscle pain, which can feel particularly severe when the patient combs their hair. The classic clinchers here include temporal headache and jaw claudication, meaning pain when chewing. You should check their past history, including their medications, allergies, family history, and so on, then perform a general physical examination and take vital signs. Also, do routine blood investigations, especially inflammatory markers like ESR and CRP, as these are often elevated in GCA. On eye examination, you may find normal external inspection initially, but visual acuity might show complete loss of vision on one side. Fundoscopy could reveal a pale optic disc. Confirmation is through a temporal artery biopsy. GCA is a serious condition that necessitates urgent high-dose steroids, in many cases intravenous, to prevent further vision loss. Advise the patient that the vision loss might be permanent, but urgent treatment can save the other eye. You'll refer them for rheumatology admission, where they'll be started on steroids and possibly painkillers. Lastly, warn them about potential symptoms in the other eye and possible steroid side effects like weight gain, osteoporosis, and hyperglycemia, and also about the DVLA implications regarding driving. Next, consider retinal detachment, which characteristically presents with sudden, often painless vision loss described as a curtain coming down over the field of vision. This can happen after recent cataract surgery or in patients with high myopia, short-sightedness. Many also report new onset floaters. A key history point is that curtain falling sensation. Your physical exam and investigations will include routine bloods for completeness, ESR, CRP if you suspect an inflammatory or vascular process, and a focused eye exam. Visual acuity might show complete or partial loss on one side, while fundoscopy can reveal a pale and detached retina. This is an ophthalmic emergency. The diagnosis is that the retina has separated from the underlying layer, and it needs urgent surgical repair to prevent irreversible damage. Refer the patient urgently to ophthalmology, advise them not to drive, and emphasize that if they notice any further changes, they must return or seek care promptly. Another important consideration is a transient ischemic attack, TIA. Patients might present with sudden vision loss. For instance, a shade coming down phenomenon called amaurosis fugax, limb weakness, slurred speech, or facial droop, all of which can resolve within 24 hours. When you suspect a TIA, recall the FAST acronym: face, arms, speech, and time. Check for a history of hypertension or other vascular risk factors. In your exam, do a general physical assessment including vitals, check their bloods, especially glucose and cholesterol, perform a cranial nerve exam, and get an ECG to rule out atrial fibrillation or other arrhythmias. A CT head might be needed to rule out an infarction or hemorrhage. TIA is a temporary disruption in blood supply to part of the brain, and management usually involves antiplatelet therapy like aspirin, often co-prescribed with a PPI to protect the stomach. Lifestyle modifications are also vital. Improve diet, exercise, quit smoking if applicable. Remind them of DVLA rules: no driving for at least 1 month post-TIA. Warn them of fast symptoms and that they must return if these symptoms recur or worsen. Now, let's discuss ocular toxoplasmosis, which commonly causes chronic blurring of vision. Patients who are immunocompromised, for example from steroid use for PMR, may be more susceptible. History of having cats at home is a big clue, and they might also complain about floaters or even neurological signs if it's severe and there is CNS involvement. Always ask about these risk factors in your past medical and social history. Perform a thorough exam, including vital signs, checking ESR and CRP, and a detailed eye exam. On fundoscopy, you might see white focal inflammation of the retina with chorioretinal scarring, sometimes described as headlights in a fog. In severe cases, do a neurological examination. The diagnosis is toxoplasma infection, often transmitted from the feces of infected cats or undercooked meat. Refer such patients urgently to ophthalmology if they're immunocompromised because they'll need antibiotic therapy, possibly combined with steroids. Advise them not to drive until their vision stabilizes, and watch for any confusion or focal neurological deficits if you suspect CNS involvement. Idiopathic intracranial hypertension, IIH, is another condition that can present with chronic headaches and blurred vision. The headaches typically worsen in the morning or with maneuvers that increase intracranial pressure, such as bending forward, sneezing, or coughing. This is more common in overweight or obese women, sometimes postpartum or in the first trimester of pregnancy. When you suspect IIH, take a good look at their BMI and also inquire about any suspicious medications. Your examination might show papilledema, swollen optic discs on fundoscopy, and you may need an MRI of the brain to exclude a mass lesion. Management involves analgesia for headache, weight reduction, and acetazolamide to reduce CSF production. In resistant cases, surgical shunting might be considered. Refer them to neurology if papilledema is confirmed. Warn them about possible permanent vision loss if it is not treated. Caution them about severe headaches, and advise no driving if vision is significantly impaired. A less common but important possibility in your differential is a suspected pituitary tumor. Patients might report multiple minor car accidents or bumping into objects on the sides because of a loss of peripheral vision, known as bitemporal hemianopia. They might literally scrape the car along barriers or objects they didn't see. In your past medical and social history, consider any endocrine symptoms, changes in body habitus, or persistent headaches. Examine them thoroughly, including vital signs and a full neurological exam. Perform routine blood work. Check inflammatory markers, then do an eye exam. Visual fields typically reveal bitemporal hemianopia, and fundoscopy can sometimes show pale optic discs if the compression has been long-standing. An MRI of the brain is crucial to image the pituitary gland. Pituitary adenoma are benign but can grow large enough to compress the optic chiasm. Refer urgently to neurology or neurosurgery for further management, which often involves surgical removal. Advise them about the danger of progressive vision loss, severe headaches, or possible loss of consciousness if complications arise, and emphasize how vision changes can affect driving. Moving on, consider age-related macular degeneration, ARMD, in older patients who complain of gradually worsening central vision. They might say straight lines look wavy or objects appear distorted. It typically affects individuals in their 50s and 60s or older. Family history, smoking, high blood pressure, and being overweight are known risk factors. Conduct a full eye exam, including an assessment for metamorphopsia, often with an Amsler grid. If you suspect wet ARMD, refer them urgently within 2 weeks to ophthalmology, as they might need intravitreal injections. Emphasize lifestyle modifications. Stop smoking, adopt a balanced diet, and exercise regularly. Warn them about any sudden loss of vision or acute distortion, as these may indicate a rapid progression from dry to wet ARMD. Next, remember diabetic retinopathy in any patient with a history of diabetes who presents with chronic blurring of vision. Often, this goes hand in hand with poor glycemic control and other diabetic complications like neuropathy or nephropathy. Ask about their diet, medication compliance, and always check their HbA1c and renal function. An eye exam might reveal hemorrhages, exudates, or neovascularization on fundoscopy. Early referral to both diabetes and ophthalmology teams is necessary if changes are noted. Treatment can include optimizing diabetic medications and advising on diet and exercise. Laser therapy or intravitreal injections may be needed for advanced retinopathy. Warn about other diabetic complications, such as foot ulcers or cardiac issues, and remind them about the DVLA if their vision is significantly compromised. We should also consider chronic glaucoma, which often presents with gradual peripheral vision loss that can go unnoticed until it's quite advanced. Sometimes it's found incidentally when measuring intraocular pressure or performing fundoscopic exams. family history is often relevant. On examination, you might find elevated intraocular pressures using tonometry and a characteristic cupping of the optic disc. It's crucial to refer urgently to ophthalmology for pressure-lowering eye drops, laser therapy, or surgery if needed. Encourage them not to stay in dark rooms or use dark sunglasses unnecessarily because dilating the pupil can increase intraocular pressure. Remind them to seek immediate help if they experience a sudden loss of vision or a severe headache, as that could be acute angle closure glaucoma. Finally, cataracts are another common cause of chronic blurring of vision, especially among the elderly. Patients may notice increased glare around lights or halos, particularly at night. There can be a history of long-term steroid use contributing to early cataract formation. During the examination, you'll notice an absent or reduced red reflex. While cataracts can be surgically corrected, you must still counsel patients to watch out for any sudden vision loss or other red flag symptoms like headache, weakness, or fast signs that might indicate a different, more acute problem. Routine ophthalmology referral is appropriate for definitive surgical treatment, and you should advise patients about DVLA regulations if their vision falls below a certain standard. In summary, blurred or lost vision can result from a variety of conditions, including GCA, retinal detachment, TIA, pituitary tumors, ocular toxoplasmosis, IIH, ARMD, diabetic retinopathy, chronic glaucoma, and cataracts. Always start with a focused history. Ask about the nature of the vision change, the presence of headaches, floaters, flashes, or wavy lines, and then proceed to a thorough examination. Check vitals, do routine bloods, and order imaging like an MRI or CT if needed. Each condition has its unique key features or clinchers, as well as specific management pathways and important warnings to discuss with the patient, especially concerning potential permanent vision loss and driving restrictions. Thank you for watching this session on blurred or loss of vision for your PLAB 2 preparation, and I hope you find this structured approach helpful in your future clinical practice. Please like and subscribe to TuringMedSchool. Good luck with your preparation.